Hello fellas. In this video I am going to talk about the hidden diagnostic clues in ethnicity, religion, and social history. Before we get started, I would like to give a disclaimer. This video is intended solely for medical education. Discussions about ethnicity, religion, culture, and social background are presented only as potential clinical clues and should never be used to stereotype or judge individuals. Every patient is unique, and diagnoses should always be based on evidence and comprehensive clinical evaluation. Let's get started. Two patients walk into your clinic. Both have anemia. One belongs to a community with a high prevalence of thalassemia. The other follows a strict vegan diet due to religious beliefs. Same symptom, different causes. Today we'll explore how ethnicity, religion, culture, and social background can influence diagnosis, and why good clinicians use these clues carefully, without making assumptions. Ethnicity and genetic diseases. Certain genetic disorders occur more frequently in specific populations because of inherited genetic patterns. Examples: sickle cell disease, thalassemia, G6PD deficiency, familial Mediterranean fever. Key message: ethnicity doesn't make the diagnosis. It simply changes the probability. Religion and cultural practices. Religious and cultural practices can influence nutrition, lifestyle, and healthcare decisions. Examples: vegetarian diets, vitamin B12 deficiency, fasting practices, hypoglycemia, diabetes management challenges, refusal of certain treatments, blood transfusion decisions in some faith communities, pilgrimage and travel, exposure to infectious diseases. Key message: religion influences health behaviors, not disease susceptibility itself. Social background and community factors. Social background may influence occupation, living conditions, access to healthcare, environmental exposures, and nutritional status. For example, people living in crowded areas like urban slums commonly have tuberculosis. People working in industries might present with chronic bronchitis, asthma, COPD. People working in mining are often exposed to dust, silica, and have poor ventilation. Hence, they may present with silicosis. Fluorosis. People in rural setting are often the victims of malnutrition and deficiency disorders. Key message: what matters medically is the exposure and living conditions, not the label. Now let's take a look at a case. A young patient presents with chronic fatigue and pallor. Initial investigations reveal microcytic hyperchromic anemia. The obvious diagnosis: iron deficiency anemia, but despite treatment, the anemia persists. That's when a careful clinician looks beyond the laboratory report. A detailed family history reveals a pattern stretching across generations. Suddenly, the clue becomes clear. The diagnosis is not iron deficiency, it is thalassemia, a genetic disorder hidden in plain sight. This is the power of family history in clinical reasoning. Sometimes, the most important investigation isn't in the laboratory, it's in the family tree. Good clinicians never stereotype, they gather clues. Ethnicity may suggest genetic risks. Religion may influence lifestyle and treatment choices. Social background may reveal important environmental exposures. But every patient is an individual. The diagnosis comes from evidence, not assumptions. Medicine is about understanding people, not judging them. The best diagnosticians recognize patterns while treating every patient as unique. If you enjoy learning clinical reasoning through real-world examples, like, share and subscribe to Diagnosis by Sherlock. Discover, analyze, diagnose.